for me to be here. We have two topics, myopia and glaucoma. Myopia has increased in importance tremendously since the prevalence of myopia, particularly in East Asia, that means Japan, South Korea, and Korea, has increased markedly in the last 30 years. And in 18-year-old school children in China, the prevalence of myopia is about 80%. And among university students, it's about 95%. This is a tremendous increase. The question is why? Of course, it cannot be genetic, since when the parents are ametropic and the children are myopic. The main reason, as studies have shown so far, is that the small children at the age of 3 or 4 spend most of their time indoors and no longer outdoors. If they spend indoors, they have all the electronic gadgets, and the Chinese symbols are quite small. And it may be, but this has not been proven, that they keep their gadgets very close, so that the developing system of the eye, under the process of ametropization, thinks the horizon is not at the horizon, but at the distance of 10 centimeters. So that the prevalence of moderate axial myopia has increased tremendously. And then there's high myopia. The border between moderate myopia and high myopia may be about at about -8 diopters, or an axial length of about 26 or 26.5 millimeters. These are more or less the cut-off value. There's a big wave warning against myopia, particularly even now in Europe and the US. Myopia is bad. Since studies have shown, again, mostly from East Asia, but also from other countries in the world, that myopia has become one of the most common causes for irreversible vision impairment of blindness. And in the Beijing eye study, for example, it was the most common cause for irreversible blindness. After, of course, with not considering cataract or undercorrection of refractive error. That myopia definitely is a problem, but it is not moderate myopia, but it is high myopia. Moderate myopia, paradoxically, is good, in my opinion, since it has more advantages than disadvantages. The disadvantage is that one needs correction, glasses or contact lenses. Some people do refractive corneal surgery. But the second disadvantage, as we all know, is that the risk of a autogenous retinal detachment increases, particularly in moderate myopia -3 to -8 or something. You know that as good as. The advantages are that in older age, axial myopia protects against age-related macular degeneration, which is one of the most common, mostly irreversible causes for blindness and vision impairment, the rest and also here. And it is protected against diabetic retinopathy, which is of course of high importance. And from a functional point of view, and it may be the most important one, as soon as one becomes at the age of 40 or plus, the myopes have the wonderful possibility just to remove their glasses and to have perfect vision. And since we are no longer hunters and collectors of berries, 10,000 years ago, where myopia was an almost a lethal factor because you could not go out. Nowadays, with computers and everything, myopia may be an advantage compared to hyperopics and ametropics. And from a cosmetic or social point of view, myopia shows the level of education. If you are myopic, since myopia is strongly connected to the level of education. Also in East Asia, because children go to school, to kindergarten and to pre-kindergarten schools, learn more, and they are myopic. And one of the key observations which led to the finding that indoors, outdoors is a major, at least superficial factor for the development of myopia was the observation of the Jewish society in Israel or somewhere else, where the Orthodox Jewish men are all myopic, -5, -10, and where the sisters of these men are ametropic, which is almost the same genes. The background is that the men, the boys, have to learn the Torah at a very young age, and the girls are allowed to play outdoors. So that this key observation led to this finding. So that if now both parents are myopic, let's say -5 or -10, both are academics, for example, doctors, and the children are not yet myopic, the best probably would be just to send them out 2 hours a day. What is easier in India than in North China, where it's quite cold in winter. And if they have started myopia, the saying is that then sending out is no longer so effective. Then one has different possibilities, either to give atropine eye drops, a concentration of 0.01%, which is very low, which may be increased to 0.02 or 0.05, perhaps even to 0.1%, depending whether the child tolerates it or not, given once a day in the evening. And somehow, but how it is unclear, it works to reduce further progression of facial myopia. Parallel to it, one can give new contact lenses, which have a clear focus at the center, but in the circular periphery, they overcorrect, so that the mid-periphery of the fundus gets an overcorrection and may think the eye is already too long and may stop giving the stimulus to the eye to get longer, however this occurs. This can be achieved either by these concentric progressive contact lenses or by concentric progressive glasses, lens glasses, which by a new technique have an increased refractive power in the periphery, circular, but in the center they have sharp focus. Or one goes to autokeratology, you know, hard contact lenses worn at night gives a clear vision at daytime, the center. But by the hard contact lens at night, probably the epithelial layers are shifted a bit away from the center, leading to a flattening of the center, steepening of the corneal periphery, the same as if you wear contact lenses or have special glasses. And that may also explain why formerly bifocals did not work. If you give bifocals to the children, and they have the near vision here, they don't look when they read or something, they just read here, because they can accommodate so fantastic. So that's the finding that bifocals did not work, but the concentric works do not contradict each other, but support themselves. Okay, that means myopia is increasing tremendously, has more advantages than disadvantages. It probably is also protective against anal closure glaucoma, probably in the East Asian population. In Indian or Western population, definitely, because the anterior chamber has some differences. So that at the bottom line, the myopic wave probably has more advantages than disadvantages. The problem is high myopia beyond -8, leading to problems. And these problems can be categorized into 2 groups: myopic macular degeneration, and what is relatively often overlooked, high myopia associated optic nerve damage. It's not very rare that highly myopic eyes get blind, not because of the macula, but because of the optic nerve atrophy. And that is easily overlooked because, as we know, due to the high myopia, the morphology of the optic nerve has changed markedly. And it is, of course, difficult to detect additional glaucoma or non-glaucoma associated changes in an optic nerve head, which anyway already looks so abnormal. And another reason is that the highly myopic patients usually go to the retina specialist, and when such a patient comes in, the retina specialist just checks the presence of the optic disc and turns attention to the macula. But the optic nerve is important. And it may be academical or not, but perhaps a lowering of pressure may be helpful, but also that is completely unclear. Okay, now if a myopic patient comes in, one can categorize the stage of so-called myopic macular degeneration into 5 stages, which may be rechanged again. But the stage 0 is nothing. A stage 1, which is also not pathological, is fundus tessellation. You see this increased visibility of the large large choroidal vessels. You already see here the gamma zone and the delta zone. Stage 2, it has further increased, so-called chorioretinal atrophy, which may not be an atrophy. It is just that it becomes even wider. And also here you see delta and gamma zone, and the optic disc starts here. Then, that's a pathology, stage 3. It's important. Yeah. Patchy atrophies or chorioretinal atrophies. Which can be very tiny and get larger over time. These are different eyes. This is pathology because there is no photoreceptor and it's an absolute localized blind spot. At stage 4, these patchy atrophies are located in the fovea. And there are plus signs, so-called letter cracks. And of course, what we know, macular neovascularization, the only element of myopic macular degeneration which is treatable so far. Good. And if one applies, for example, the scheme into a follow-up, and this was the GEI study, which was repeated after 10 years in 2011, we see at the beginnings, this is the optic disc. So then this may be the border between so-called delta zone, and this may be gamma zone. Gamma zone is the white one, and delta zone, there may be a delineation. But in particular, we see that 10 years later, if this was a questionable patchy atrophy, it has enlarged. Here are the letter cracks, here is a large patchy atrophy, and also gamma and delta has enlarged. That means there was first gamma and delta, then the development of patchy atrophies, which further just in 10 years. And if this patient had come to us on Monday and asked, what is my fate? Probably I would have said, oh, you're highly myopic, just be happy that you don't get a retinal detachment and have a healthy life. But it has remarkably increased in 10 years. And if he is just 50, one doesn't know how to go on further. And in this population-based group, without referral bias, 71% of those with the diffuse chorioretinal atrophy, resolution is still 2020, progressed, and all eyes with patchy atrophy progressed. That means the risk of progression, highly myopic eyes, is relatively high. What one may not really have realized so far in the clinics, because the patients come in once, one tells them, go to the optician, we can't do anything for you, and they don't come back. The risk of progression is relatively high. And the risk factors in the GEI study were more marked myopia, older age, a smaller gamma zone at the end of the follow-up, and females. Then there was a large hospital-based study in Tokyo on 800 highly myopic eyes. And there again, the progression rate was almost 100% in those with patchy atrophies, with a higher number, including a potential referral bias. And all eyes with letter cracks also, or many eyes, progress. There's a high risk of progression. 810 eyes, and the actual length was quite long, 29 millimeters. And again, it were more the ladies than the men, old age, longer actual length at baseline, but most importantly, decreasing axial length. That means it is not only that high myopic eyes have a risk of progression of the morphology, they're also the eyes get longer. Not only in that study, but also I think in 3 other studies published so far, the myopic or the highly myopic eye usually is not stable, but continues to get longer. And in this study, that was the most important or the only modifiable risk factor for progression. This is a chance. If we understand how and why the eye gets longer, and if we can block it, we may have a possibility to block or to reduce further progression of macular degeneration or high myopia associated optic nerve damage, and to reduce the risk of vision deterioration. And finally, there are two studies now which show that the eyes can become shorter. This was completely unexpected. It's unclear how that occurs. It's also not fully confirmed, but at least there's that possibility. And fitting with the waiting eye study that there is, or a study that there is indeed a risk of further progression. These are the results of a population-based study in Russia on a group of individuals aged 85 years or higher, that means very old, examined in a population-based manner. And here you see that the highly myopic eyes had a prevalence of close to 80%. Myopic macular degeneration, stage 3 or 4, PET-GA copies. And these were not really highly educated people that came from the countryside and from the city in Ufa, which is a city about 1,400 kilometers east of Moscow, where they 1 week ago had a temperature of minus 52 degrees Celsius at night. There's the winter you live in your house and you usually don't go out. This is as a result. I mean, if this is correct, it can be transferred onto the normal on other populations, may indicate that almost all highly myopic eyes get stage 3 or stage 4 of myopic macular degeneration if they get old enough. Perhaps it's similar to glaucoma, to a situation where the pressure is 25, where you can't do anything, but the risk of getting blind may be 80% at the age of 85 and 90 years. This can be abstract, but these are the data. And here are some follow-ups. You see the white, let's call it gamma, and then this is delta, and this is the optic disc. Then you have, after some time, early patchy atrophies and lacquer cuts, which widen. Gamma and delta get wider, and also the patchy atrophies get wider. The vision is still 20/20, but with that, what we have heard so far, and if you just see this follow-up, there may be a risk that the fovea gets sometimes affected. So that we have this patient who has is decreasing in vision under our hand, and we don't have any means so far. That's the question. Other examples have on first gamma and delta increasing. Here's at least pre-original atrophies, and then you get HG atrophies which get larger and larger. Now, if you want to address the question, if you want to help the patient and to see that last eye, one eye is lost by myopic macular degeneration stage 4, the other eye has HGA of his vision 20/20, socially and professionally fully active, is a fact. He knows that it can go down because he has experienced it in the other eye. What can be done? The first step, as made for MD, try to understand or to explore how and why the eye gets longer. And we are clinical scientists. We are not basic scientists. The thing what both have in common is that they look for the needle in the staple of pain. The difference is the basic scientist does not know how the needle looks like. We clinicians know it because we know the end stage of the disease. We know how the needle looks like, and if we know it, it's much easier to find it. That means we need to concentrate on our strengths, on all the clinical experience we gather in so many hours and that we don't have any time left for research, but try to understand what we see and put it together into a puzzle to get the whole image. Okay, the patchy atrophy here is in OCT-based histology, a defect in the RPE. Of course, the photoreceptors in the center are also lost, but it is also a defect in post-membrane. We have a larger defect in the RPE, and in the center, a smaller defect, usually post-membrane. And of course, it's an absolute scotoma. And if you go to histology, you find the same. here is the end of the RPE. That means all this black is the patchy atrophy. Here ends the post-membrane, which is hardly to see. And then you have here no photoreceptors. It is as if the RPE layer being under tension gets an expansion hold, and slips away under the retina, so that the photoreceptors are still here, but the carpet has been torn away. And if that is a place of maximal tension strain in the RPE, there may be also the same in the post-membrane, which may also get expansion hold. And the retinal changes are just secondary. This is all speculation, but these are the anatomical facts. And here you see the splitting up of post-membrane at the margin of the post-membrane hole, and post-membrane thickness is normal. Post-membrane thickness does not change with axial elongation. In contrast, the choroid and the sclera. And there are, of course, changes in the optic nerve, leading a high myopia leading to a secondary macro disc. The border of the disc may be here. It's a bit difficult to see from here, but here it is easier again. This is the peripapillary wing of the optic. This is the wall. This is the secondary macrodisc, and this is a primary macrodisc with a pseudoprochromatous but normal macrocup in an anatomic eye. And the secondary macrodisc, the large optic disc, is a major risk factor for optic nerve damage, for glaucomatous optic nerve damage, or glaucoma-like optic nerve damage, since the association with IOP has not been shown yet. But it is glaucoma-like because one has a vessel kinking at the optic disc border here, also here, and also here. And if you see it in one position, you can be quite sure that all neuroretinal rim is lost. That means this eye got blind because of the optic nerve, independently what the macula looks like. Of course, they also have concentric visual field constriction. And the risk of glaucomatous or glaucoma-like optic neuropathy went up to 80% in the extremely myopic group, up to 80%. What may be the reason for this? One reason is, one anatomical fact is that if the disc gets larger, laminar corposa gets thinner, probably by the stretching. And that means a morphological change in the laminar corposa. This by itself can already lead to compression or what else of the fibers going through. But also the distance between the intravitreous cavity with the so-called intraocular pressure and the retrobulbar pressure, which is the orbital cerebrospinal fluid pressure, the distance between these two compartments gets shorter. And even if the IOP is unchanged, and if the orbital CSF pressure is unchanged, but if the distance gets shorter, the gradient gets steeper, which may be one of the reasons for an increased glaucoma-like optic neuropathy in the highly myopic eye. And the lamina can become as thin as 50 micrometers. Normally, it is 250 microns. There are tremendous morphological changes. And this is just the pyromata. This is the laminar corposa in an eye with an absolute glaucoma. And then there are parapapillary changes in the parapapillary region, which can be summarized as zone alpha, beta, gamma, and delta. Okay, alpha zone is defined by the presence of post-membrane and presence of an irregular RPE. Beta zone is defined by the presence of post-membrane, but no RPE, quite easily. And we see that in beta zone, the photoreceptors extend into beta zone, or there are no RPE cells, but they stop here. But since there are no RPE cells, it is an absolute scotoma. And beta is associated also with glaucoma, as we know. If this is a glaucomatous optic disc in a non-highly myopic eye. We have here the peripapillary wing, which I will come to later. And this would be beta zone, where we see the large choroidal vessels, and this irregular zone is the alpha zone. Same on that side. And looking now for the etiology of beta zone in the glaucomatous eyes, there was an observation where one put patients with a narrow anterior chamber ankle into a dark room for 2 hours, a dark room adaptation test, and observed this as a special radar. And some of them got an OCT at baseline, and 2 hours later, when the IOP was elevated. And we see a change in the morphology of the end of the RPE, as if post-membrane, as if the end of the RPE has been shifted away from the optic disc, leading to a small fold of the carpet. The same can be seen here. You also see that there is apparently an enlargement of beta zone at the time that the IOP is high, taking to the observation that the RP is a bit pushed away from the optic disc movement. Interestingly, in light microscopy, one relatively often finds parapapillary intrusion. So that the hypothesis is that in glaucoma, the beta zone develops by an IOP fluctuation-dependent shifting of the end of post-membrane away and again to the optic disc, and this may lead to a mechanical or what else alteration and irritation of the RPE, leading to a drusen formation, which is a production of sub-RPE basal membrane material, and finally to the loss of the RPE cell beta zone. And we know there's a beta zone in highly myopic eyes. This is evidently a highly myopic eye where we see all this does not have RPE. And formally, I call it gamma zone, but in reality, can be both. But at least this tight zone does not have RPE, and there's almost no alpha zone, no irregular RPE yet peripheral to it. And if we go back again to histology, we see in this highly myopic eye, this is post-membrane going to the, here would be the optic disc. Post-membrane has a normal thickness, and here's the RPE almost without alteration. This, I don't know what. So that glaucomatous beta zone maybe is a shifting, and myopic beta zone maybe just an enlargement of the physiological opening of the RPE, because the optic nerve channel has different layers. It has first the opening of the RPE opening, then the opening of post-membrane, which is the post-membrane opening, then the opening in the choroid, which may be the choroidal opening, and then comes the bottom, which is the lamina proposa. And we know that axial elongation leads to an increase in the inner surface of the eye, because myopic axial elongation occurs mostly behind posterior to the equator. So that the distance from the ora serrata to the optic disc enlarges. And according to a study by my wife, for example, for each millimeter elongation, the distance between the ora serrata and the disc enlarges by about 0.7 millimeters. This indicates that the layers get stretched, including the RPE layer. That there is increased strain, perhaps leading first to an enlargement of the already existing hole, which is the RPE opening of the optic nerve canal. If that gets larger, you have beta zone, because you have post-membrane underlying, but no RPE on top. And we know that the RPE with its basal membrane is not firmly connected to post-membrane. The textbook is written, the post-membrane is composed of 5 layers, RPE basal membrane, collagen, elastic, and collagen layer, and then the basal membrane of the pluricapillary. At least from a biomechanical point of view, it's only 3 layers. Collagen, elastin is collagen, like a plywood. The basal membranes are just attached to it. And if you go to age-related macular degeneration, we know there are RPE detachments. And what is detached? It is not the RPE cells, it's the RPE basal membrane, Because if the basal membrane would remain at the post-membrane and also only cells were detached, they could not keep the line. They are not firmly connected to each other. It's the basal membrane which gives them the support. That means an RPE detachment is an RPE basal membrane detachment, clearly showing that the RPE basal membrane is not firmly connected to the post-membrane. It can also fly. Under checking this hypothesis that the myopic decazone is an enlargement of the RPE opening due to a sliding of post-membrane, the sliding of the RPE on post-membrane. This was alpha and beta. And you can use it on Monday morning, the first patient to see, and of course also the second. Then there's the possibility that post-membrane does not extend to the end of the optic disc. Optic disc defined by the end of the lamina corposa. And that means there's no post-membrane, not fulfilling the definition of ultrasound, which is post-membrane present and irregular RPE, nor fulfilling the definition of beta zone. Both yes, but no RPE, yes, no both. And if it's not alpha and beta, let's call it gamma. This is gamma zone. Okay, this is a clinical observation. This is a 17-year-old adolescent, moderately myopic, but undergoing increasing myopization. And we see that, with increasing myopia, gamma zone gets wider, and correspondingly, the horizontal disc diameter gets shorter. And optic disc defined as that part of the lamina corposa covered or uncovered by the neural rim, which is ophthalmoscopically visible. And we see that the circular optic disc shape changes to a vertically oval structure. These are anatomical facts. And all of us know that the moderately myopic eyes usually tend to have a vertical optic disc, and often the disc is not very large. It used to be relatively small. They have these oblique optic nerve exits as an anatomical fact. And the question is, what have we not detected? What we have seen for 5, 10, or 40 years? We just must realize what we have seen and then put it together. That means we all agree moderately myopic eyes tend to have a vertical disc shape and often a relatively small disc. And if we just have a look into OCT, we see that eyes is a gamma zone, moderately myopic eyes, has correspondingly an overhanging of post-membrane on the other side, almost fitting 1 to 1. And the part of the lamina covered or uncovered by the rim, which is visible to ophthalmoscopy, of course, gets shorter because another part of the lamina is covered by the post-membrane overhang. So then we have here a misalignment of the 3 layers of the optic nerve panel. Also here, on the nasal side, we have the overhanging. We have the overhanging of post-membrane here, and corresponding here, gamma zone, the leg of post-membrane. This led to the hypothesis that the 3 layers, that the layers of the optic nerve panel, which are normally aligned when one is born, get shifted. That means there is a shift of post-membrane into direction of the forelobe, leading to an overhanging on the nasal side and a lack of post-membrane in the lateral side, just as speculated hypothesis. And we see that in gamma zone, okay, here's another example of gamma zone, and we see that the photoreceptors extend into gamma zone and the inner layers extend even more, just as if post-membrane has been pulled away, leaving the furniture standing on the carpet more or less still in place. The same we can see in histology, where the photoreceptors and also the inner nucleus photoreceptor layer and also the inner layer far extend here into beta zone where postmembrane is present, and also gamma zone. Now, that means in moderate myopia, there may be a shift of postmembrane leading to the development of gamma zone on the temporal side. In highly myopic eyes, we have a circular gamma zone, and this fits OCT studies which showed an enlargement of the postmembrane opening in high myopia, so that there the postmembrane opening gets wider, perhaps similar to the widening of the RPE opening due to this stretching, leading to a retraction of the overhanging part of the postmembrane, so that one sees the full laminar precosa and gets a large optic disc and a circular gamma zone. This is one of the reasons to differentiate between moderate myopia and high myopia. That high myopia, what has a widening, leading to a retraction of the overhanging part of postmembrane in the parapapillary region, that one has gamma zone circular. Then delta zone. Delta zone is again based on anatomy. Here we see a normal optic nerve on an anisotropic eye. We see that the posterior sclera does not extend in full to the laminar precosa, but that the outer half of the sclera merges with the dura mater. And only the inner half extends to the laminar precosa with the so-called peripapillary scleral flange. This the biomechanical anchor of the laminar precosa simultaneously forms the interior border of the orbital CSF space. In highly myopic eyes now, this scleral flange, which normally has a length in the width of 0.5 millimeters, is extended by a factor of 10. Here it is about 5 millimeters, the same scale, but its width has been reduced to 10%. Because it cannot increase in volume, there is no growth of tissue, it is just a rearrangement of the collagen fibers. And if this is the biomechanical anchor of the laminar precosa, then this change in the scleral flange will have importance for the glaucoma susceptibility in the laminar precosa. And this is then called delta. That means delta zone is a part of gamma zone located at the optic disc border and characterized by an elongation and thinning of the peripapillary scleral flange and is bordered by the merging line of the dura mater with the sclera. And we ophthalmologists could do a CSF puncture, not a lumbar puncture, but a peripapillary scleral flange puncture to get CSF fluid just by penetrating this 50 micrometer thick tissue. So it's through the nerve layer. Just to illustrate the anatomy. Now, there were two major risk factors or factors associated with the prevalence of a glaucoma-like optic neuropathy in high myopic eyes. It was one, the large optic disc, and the second was the large delta zone. Yeah, alpha, beta, gamma, delta. And if you see the next highly myopic patient on Monday morning, and if you do test yourself an OCT, then not quite rarely we see this scleral ridge in the parapapillary region on the temporal side, coinciding with this demarcation line. This is the image of the patient eye study, an image taken under routine conditions with 100 participants having to be examined on a day. And if you see the fovea is not here, not on this slide. And here's another example where we see this demarcation line coinciding with the scleral flange. And this may be the merging line of the dura mater. This is not the same line. This is sclera. This would all be delta. And this may be gamma and beta, because there's no RPE. And how may this scleral flange develop? Perhaps due to a biomechanical action of the optic nerve. We know that high myopia means an axial elongation. The eye becomes quite long. Now, if this eye adducts, then the posterior cone is moved forward, more forward than in a short ametropic eye. This can lead to the situation that the optic nerve becomes too short to allow a full adduction of the eye. This will lead to a backward pull by following the dura mater of the optic nerve on the optic nerve structures. And where? The nasal or temporal side? No, on the temporal side. Because the optic nerve comes from the nasal side and the temporal side is most distant straight. And temporal inferior more than temporal superior, because the optic nerve originally, as its origin, is the nasal superior part of the organ. This can lead to a vertical rotation of the optic nerve in adduction, and maybe increase another biomechanical factor and stress for the optic nerve. There are models suggesting that such an adduction may lead to a force similar to a pressure of 50 millimeters mercury. This is just theory, but at least there may be a mechanical backward pull by the optic nerve becoming too short for adduction of an actually elongated eye. But, and this fits also with the development of peripapillary suprachoroidal cavitations in the nasal inferior part of the parapapillary region in highly myopic eyes, which upon ophthalmoscopy have a yellow color. In OCT, we see this cavitation. Perhaps it can be explained by the optic nerve pull as if the dura mater pulls backward the sclera and leaves the choroid attached to the proximal plane in the normal position. There is no pathology, no functional deficit, but it could be explained. Now, if such an eye is in primary position, then the posterior pole is located more posteriorly than in the short ametropic. That situation, including perhaps an increased orbital tissue pressure because there is not enough space, the optic nerve may indent with the peripapillary tissue. And since in delta zone and gamma zone, the structural support is much weaker, there is no proximal plane, it may lead to an indentation. So that is very rich in primary position, maybe an indentation by the optic nerve, which doesn't find enough space in the condensed posterior orbital compartment in highly myopic patient. And if the eye adducts, it may pull it back. This is only theory. This was the glaucomatous or glaucoma-like optic neuropathy in high myopia, defined by the occurrence of a glaucoma-like optic nerve appearance, that means small rib or vessel kinking close to the optic disc, usually in eyes with a normal intraocular pressure. It is called glaucoma-like because up to now it has not been shown that a therapeutic reduction of IOP in that situation is helpful, which may belong to the definition of glaucoma. These studies are going on in China with 1,000 patients or so. One has to wait. But if it has a patient, minus 15, minus 20, vision 20/20, some patchy atrophy, visual field defects, better with glaucon than with octopus or something. And if one believes that the vessel kinking is a bit too close to the optic disc as it should be, in case of doubt, one may discuss with the patient to lower the IOP, particularly if the eye drops are well tolerated. What should it harm? In case of doubt, may help. Also, there are some speculations that reduction in IOP may be helpful to reduce further myopia progression. This is very speculative, but if it does not harm, one may keep the eye out. For patients, there is no evidence-based data, but one may use it. Besides, it's not glaucoma-like optic neuropathy, there's a non-glaucomatous optic nerve damage, of course, which can also pull inside. That means the shape of the ring is normal. The isn't whole is completely fulfilled, but the optic disc looks pale and the nerve layer thickness is reduced as far as one can measure. And here in the Russian study, the oral eye study, not at the very old, but there was another study on these patients and participants with an age of 40 plus. The prevalence of the non-glaucomatous optic nerve damage also increased up to 80%, highly myopic group. So that one can say that the high or extremely highly myopic group, almost all eyes have an optic nerve damage, non-glaucomatous and often also glaucoma like, perhaps with a different pathogenesis, but both hitting the optic nerve. And this is the study, and the reason is why. Why does the optic nerve get damaged in a normal IOP eye, just highly myopic? The distance between the retinal ganglion cell located in the periphery of the optic disc increases by 0.7 millimeters or 1 millimeter axial elongation. Just going back to a simple anatomy. The eye gets longer, the inner surface gets longer, because it's mostly the extension of the posterior part. The distance between ova serrata and the disc gets longer, leading to a stretching in the RPE layer, perhaps leading to an enlargement of the RPE opening of the optic nerve canal, and then secondary expansion both in the macula, GEI proteins. But which other structures are affected? The photoreceptors are primarily not affected. They may get a larger distance, but nothing else. The inner nuclear layer, no complex, just a lower density. The only two structures which connect the retina to the optic nerve are the inner limiting membrane and the optic nerve fibers. Only these two structures, retinal structures, are directly affected by the increased distance to the optic disc. Shall I start?
Should be all right. Why they go for some more time? Yeah, there's nothing.
Okay. That means one may speculate that due to the increased distance, the nerve fibers are stretched and may go down. And we know that all eyes who have a gamma zone have an increased distance from the optic disc to the fovea, because it has shifted. The disc remained here and the BNO shifted to there, so that the distance to the fovea increased 1 to 1 by the width of gamma zone. And the fibers, the ganglion cells, which are located here, or which were located here, okay, their axons are directly stretched, potentially leading to a loss of the macular ganglion cells, leading to a dense central sclerotoma, even if the macula is completely normal. And if you see this OCT, where we see here, the end of post-membrane, long distance to the optic disc, this tissue may be just clear tissue, but no longer no fiber. Here we see the orbital fat. This may perhaps be the dura mater, and this is the orbital CSF space. And this is a patient who got the OCT spectralis under routine conditions. And of course, if you have a PTA atrophy with a large post-membrane defect, widening, then you have also a stretching of the overlying tissue, because if the underground gets wider, the overlying tissue gets stretched, leading to a non-glaucomatous optic nerve damage. Now, in the last 4 minutes, if we try to put together all these morphological findings, which we, and also you on Monday morning, will see in any patient, will detect in any patient sitting in front of you, and this is just the list of all these changes. The question is, how can we put it together? And the very, very speculative hypothesis, based on the anatomical facts, is that the eye gets longer by growth of post-membrane in the mid-periphery, periphery to the optic disc. There, the eye may get longer. Hints speaking in favor of this hypothesis. First, the evidence that the new contact lenses and the new glasses, which lead to an overcorrection in the mid-periphery, have an effect. And if there's a sensory part of the feedback mechanism governing the axial elongation, it would make sense to have also the efferent part there. Second, we know that the cord gets thinner with elongation. This can only be explained by a backward movement of post-membrane, the posterior pool of post-membrane, more than a backward movement of the sclera. Otherwise, the distance would become wider. It could be achieved by an active growth of post-membrane in the mid-periphery, pushing the posterior part backward. The scleral volume does not change, so that scleral thinning is just a rearrangement of the available tissue, the same with the cord. Post-membrane thickness, as pointed out before, is independent of axial length. Its volume increases, fitting with an active growth. Then eyes with a congenital defect in post-membrane have a localized scleral staphylomas, as if post-membrane is a biomechanical important structure for the eye. Eyes with a secondary defect in post-membrane as in toxoplasmosis have a localized scleral staphylomas. The choriocapillaries, the density, histology is independent of axial length, fitting with the hypothesis that also post-membrane thickness is independent as a posterior approach. The density of the RPE set at the posterior pole is independent of axial length but decreases in the mid-periphery, so post-membrane may get larger. Also, the photoreceptors decrease in the mid-periphery but are independent of axial length in the center. Also fitting that the thickness of the retina in myopic eyes is normal. They have a wonderful fovea, -10, -50 diopter eyes. Wonderful fovea, the choroid capillaries may be normal, just the choroid which becomes thinner. And the shift may be explained by an enlargement of post-membrane peripheral to the optic disc. And finally, maculoschisis, if the inner limiting membrane is the other structure which is firmly connected to the optic disc and which gets stretched, and if one has an additional scleral staphyloma, then post-membrane can slip backward. But the ILM is firmly connected, perhaps leading to a washing line phenomenon explaining the development of myopic maculoschisis. Thank you very much.
Questions? Any questions? I have always, from what you said, what I have understood is the staphylomatous changes is primarily related to the changes in the Bruch's membrane. That's what you said. I mean, because I was under the impression that it's basically a scleral thinning that causes the staphylomas.
If one goes further, if post-membrane enlarges, but if perhaps on one side the enlargement is more than the other side, one may get a macular ridge, and which can often be relatively often be seen. And if one has a scleral staphyloma, it theoretically may be that one has a localized enlargement of post-membrane, pushing the sclera outward and leading to a staphyloma. So that theoretical, in the eyes with staphylomas, the growth of post-membrane in the mid-periphery was not equal in all meridians, but just localized. Then you get an outpouching. This is all speculation, but this will explain the development of staphylomas based on post-membrane. And take a pig's eye and open the sclera by a window of 1 by 0.5 centimeter. If you squeeze the eye, we need a pressure of about 100 millimeter mercury to make post-membrane burst. That means the biomechanical strength of post-membrane is about 100 times higher than that of the sclera in relationship to the thickness. That the question theoretically perhaps scleral staphyloma is the secondary outward pouching of the sclera due to a localized outward pouching of post-membrane due to a localized overproduction of post-membrane in the process of axial application, misregulation. This is highly speculative, but perhaps it makes sense.
The second question is, as far as glaucoma is concerned in myopia, there are a lot of people who may be having here normal intraocular pressure. It may not always be a high intraocular pressure. So in such a situation, according to you, what is the most important diagnostic modality? Is it the optic disc photography? Because the OCT RNFL is very unpredictable. Visual fields also may not be very predictable because they may have associated myopic maculopathy. So do you think that the optic disc photography is a useful method by which you can diagnose? We spoke about these various zones. So how do you do that in your clinic and what do you advise for clinicians?
I fully agree with you. I think the best technique is just to have a look at the optic disc, ophthalmoscopically or on a normal disc photo, and look for the vessel kinking. If you think that the vessel kinking shows a normal shape, then fine. If you think that the vessel kinking is too close to the optic disc, or even at the optic disc, then it's highly likely optic nerve damage or coma line. This cannot be picked up by OCT. A follow-up is even more difficult. In case of doubt, I would lower the pressure. Even if the patient reports my vision gets down, then even do it try to under 10 with kinase inhibitors, where you have a chance to get it lower than that.
You said moderate myopia is protective in many ways. But why is that moderate myopes are more prone for retinal detachment than high myopes?
I would not know, but I would think that in moderate myopia, the vitreous is still firm enough to have a mechanical force to lead to tearing. In highly myopic eyes, first, the vitreous is already so fluid that it no longer has a force, and second, one has a couple stones, the periphery, which may also lead to a stronger adhesion. But the mechanical force by the vitreous body may also be factor.
Is there any way by which we can prevent this loose membrane sleeping? That's the key to the axillary elongation.
Yeah, I think another 2 minutes. The question is now, if this all is valid, the question is, by which means does the retina tell the RPE in the mid-periphery producing more carpet, more pulsing brain? What is the message? They don't have a phone, they don't have nerves, they will probably do it like smoke, as the Red Indians did it. That means they produce a molecule which will diffuse through the retina with the physiological fluid transfer through the retina to the RPE to the cold capillaries. That means when it's looking for a molecule, a messenger molecule, indicating the RPE to produce more pulsing brain. Our hypothesis is that it is EGF, epidermal growth factor. There have been several studies performed in different flags. Guinea pigs, if you inject EGF, the eyes get longer. If you block it by an EGF antibody, the eyes get less long in guinea pigs and in monkeys. Now, if that is valid, it's like a card house where you put card on card, and if you remove one card, it all collapses. If that is valid, then the beauty of the situation is that EGF antibodies have been in clinical use for 20 years in oncology for the treatment of lung and neck cancer. And the colleagues in Russia have done a phase 1 study in highly myopic adult patients where they injected this oncological drug into the eye, and it was well tolerated. And now preparations are going on to do a phase 1/2 study under good clinical conditions where one injects these oncological drugs into the eye. This is theory. Whether it works is completely unclear. But this or other antibodies may come up as soon as one has really found the myopia growth factor, which may be a normal growth factor.
Last question. What's the role of genetics?
Genetics, if you take the whole myopic group and one has found 100 genes associated with myopia, and even if one forms a polygenetic score, it explains 20% or less of all myopia. But as soon as you go to families with myopia, particularly with high myopia, the other genes may play a much larger role. And myopia will also not be myopia. Myopia is Stickler syndrome, definitely different in the pathomechanism than from myopia in other situations.
Do genetic study in such patients?
No. I mean, in Stickler, of course, if one has a patient, but in myopia, it has no use for it.
Small innovative. I have met you many, many years ago. You did the epidemiological study with Vinay Nandi in Nagpur. So I happened to be there once. You had come for that meeting. So I have read many of your articles on triangle law, intravitreal and secondary. Very familiar. Thank you very much.